Next, we are going to discuss total anomalous pulmonary venous return. This pathology represents around 1% of congenital heart diseases, in which there is no direct communication between the pulmonary venous system and the left atrium. Instead, these pulmonary veins are draining into the right atrium, and according to this drainage, the defect is divided into 4 different types. The first type is supracardiac type, which represents 50% of total anomalous pulmonary venous drainage patients. The common pulmonary venous sinus drains into a left vertical vein, which goes cranially to connect to the innominate vein, which in turn drains into the right SVC. The second type is the cardiac type. This type represents around 20% of cases where the pulmonary veins enter the RA separately through 4 openings or drain by a common pulmonary venous sinus into the coronary sinus to the RA. The third type is the infracardiac type, which represents around 20% of cases. The common pulmonary venous sinus drains in the abdomen through the portal vein, ductus venosus, hepatic vein, or IVC. This vein penetrates the diaphragm through the esophageal hiatus. The fourth type is mixed type, which represents around 10% of cases. In many cases, there may be pulmonary venous return obstruction, resulting in rapid development of pulmonary hypertension. These patients usually present with pulmonary venous congestion, hypoxia, and systemic hypoperfusion. An interatrial communication is mandatory for survival of these patients. The left side of the heart is usually relatively smooth. The clinical manifestations in these patients differ depending on whether there is obstruction of the pulmonary venous return or not. In case there is no pulmonary venous obstruction, the patient presents like left to right shunt with congestive heart failure, growth retardation, frequent lung infection in infancy, and there is mild cyanosis starting from birth. On examination, the child is malnourished, mildly cyanotic, with manifestations of congestive heart failure. By local cardiac examination, there is widely split second sound. The second sound may be accentuated because of pulmonary hypertension. There is grade 2 to 3 ejection systolic murmur due to pulmonary overflow. There is mid-diastolic rumbling murmur over the tricuspid area due to increased flow across the tricuspid valley. ECG presents with right ventricular hypertrophy and occasionally right atrial hypertrophy. Chest X-ray may reveal moderate to marked cardiomegaly involving the right atrium and right ventricle with increased pulmonary vascular markings. There may be the snowman sign or the figure of 8 configuration, which may be seen in cases with supracardiac type. Patients with pulmonary venous obstruction present with marked cyanosis and respiratory distress since the neonatal period. Physically, these patients show cyanosis, tachypnea, and retractions in these patients who are malnourished. Chest examination will show the pulmonary crackles, hepatomegaly. ECG shows right ventricular hypertrophy or right atrial hypertrophy. Chest X-ray shows a normal heart size or slightly enlarged, with lung fields showing evidence of pulmonary congestion up to pulmonary edema. Echo examination will show the diagnostic features of the total anomalous. with a large right ventricle and compressed left ventricle, large right atrium with small left atrium, and deviation of the atrial septum towards the left side, pulmonary artery branches dilatation. The interatrial communication is necessary for survival, either PFO or ASD. There may be a large common chamber posterior to the left atrium, draining these pulmonary veins. Doppler studies may show increased flow velocity across the pulmonary artery or the tricuspid valve, or even over the pulmonary veins. Echo will also show the features of each type with the common pulmonary venous confluence draining into the specific site, whether in the supracardiac type, the cardiac, or the infracardiac, differentiating the different types. And sometimes we may need other modalities like multi-slice CT angiography to differentiate between different types. So what is the fate of these patients without surgical intervention? Congestive heart failure will develop in all types of total anomalous pulmonary venous return with gross retardation and repeated chest infections. Without surgical intervention, 2/3 of patients without obstruction will die before the age of 1 year, usually of superimposed pneumonia. Patients with obstruction rarely survive more than few weeks without surgery, mostly die before 2 months of age. Management of these cases include medical management with intensive anticongestive measures and diuretics for patients without pulmonary venous obstruction. In case of metabolic acidosis, should be treated properly. Patients with severe pulmonary hypertension and cyanosis may be treated with prostaglandin E1 to keep the ductus open and improve oxygen saturation. All patients with total anomalous pulmonary venous drainage will definitely need surgical intervention. But it is urgent for patients with obstruction. They should be operated soon after diagnosis in neonatal period. Patients without venous obstruction can be operated late in the age of 4 to 6 months. The procedures depend on the type of the pathology, and all the procedures intend to redirect the pulmonary venous return back to the left atrium.